we'll be talking about simple tips to make Phaco easy. And I would like to call upon Dr. Venkatesh to take us through easy steps, or what do you say, pearls to get a perfect capsular rhexis.
Good afternoon, everyone. Today, I'm dealing with the pearls to get a perfect capsular rhexis. What is basically an capsular rhexis? Means it's just an opening we are made on the anterior lens capsule. Whatever the technique may be, just we have to remove the nucleus. Then later on, accordingly, whichever the technique you are following, you please go ahead. Here there is an anatomy of the lens. Basically, how does it looks? The anterior part, the posterior. And I just want to specify here is the thickness of the lens as such, like the anterior part and the posterior, the equatorial. Ideally speaking, this for posterior capsule is very thinner as such, like. Now let us discuss what do you mean by capsulotomy. Like normally we do the capsulotomy earlier. It is 3 types as such, like. The first one is the can opener capsulotomy, where a rag but a circular opening in the anterior capsule by creating a multiple puncture. We do a multiple puncture as such, like, but it has its own advantages and the disadvantages, like it is easy to learn, it facilitates the superior nuclear prolapse, and easy to do in a small pupil case. Removal of subincisional cortex is very easier, but at the same time the disadvantages are there will be a lot of radial tears, and capsule tags may occlude in the irrigation aspiration port. Sometimes there will be an eye wall decentration. And also there will be poor support for the PCI wall in a PCR. The other technique is the envelope technique. The envelope technique, where we do a linear incision made in the upper 1/3 to the middle 1/3 of the anterior capsule. Again, it has its advantages and the disadvantages part. Its then advantages is the minimal tissue trauma will be there, almost intact capsular bag. Capsular polishing is very easier. In a case of PC rent, we can implant the lens in the anterior sulcus IOL as such, like. Now, let us come to the main thing what we have been doing as such. That is called as a continuous curvilinear capsular rhexis, like. So it is independently developed by Drs. Howard Gimbel and Thomas Newman. It is universally acknowledged, like, as one of the fundamental elements of modern Phaco surgical technique. What is the physics behind? First, this is the technique usually I followed. Here, the video.
Can you start the video, please? So one of the plus you should always remember when you're doing a CCC, first is a nice long nick. So we have a tendency to do a small flap, then turn, then try to swirl like this. Don't do that. Do one nick in straight line and have a nice big flap. Okay? Start it just below the Purkinje images you see, no? You can start just below, make a nick, lift up the flap. And now what is very, very important is, if you see, our concentration is where we are trying to touch the capsule. That is our tendency, no? Wherever we are going to press the capsule is where our attention goes. Please don't do that. So where you have to keep your eye on is where the tear is. Keep observing where the tear is. Automatically, you won't believe. Suddenly your rhexis will become the right size and it'll be round. So keep that in mind. Please go ahead.
Here, what the thing I usually prefer as such, like, first I will consider the first Purkinje's images. I do start from the center, either by a small radial cut. From the center to the extent, usually I make it around 2 mm of rhexis slide with a linear cut. At the tip portion, I just lift it. By lifting it, almost around 0.25 to 0.5 mm is again extended, such that it will be something around 2.5 there, if you complete, this is what is called as a radius part. If you complete the whole rexis, it comes something around 5 mm rexis like. What is the physics behind it like? Before going to the physics part, basically I just want to tell the 3 important things that is taking place in an rexis part. Number 1 is the force, and number 2 is the stress, and the third one is the strain. I will just demonstrate with a small test like. What is an shearing technique or the shearing force? Just take a paper. If you just take a paper, see here you just hold it. If you hold, if in the center of the point, if you just stare it like. If you just stare it like. Here the force will be acting exactly in this portion. The other part, there is not much of a strain. This is called as an shearing force, where in a regular rexis we are following as a shearing force technique. Similarly, just see in the figure. Area X remains stationary while area Y is pulled from point A to point B in order to tear this material from point A to point B. This is a little bit of a mathematical, I just don't want to go in depth. And ultimately all the pulling force, all the pulling force is concentrated this portion like. At point of the tearing, even though the Y portion be engaged by the cystitome. Now coming to the ripping force. This is what I told is the shearing technique, whereas the ripping is, in a shearing technique, only single capsular layer is affected. Whereas in a case of a ripping, I am applying a force, that the force in a shearing is in that manner, but in a ripping force, just see it like. If you pull it there, here, the ripping force, both the sides, the force is acting. Especially in a ripping force, the number of zonules or the number of capsule damage is more. That is, it's more than 2 to 3 or 4 as such like. Sometimes we have to use both shearing, that of a ripping force, simultaneously in the case of an intermittent cataract or whenever there is an vitreous thrust. This again, just focus on that part, the right lower. If you just do a complete rexis, note the loss of symmetry. It's look like a bullet type, like the point A, bullet shape configuration instead of a continuous mirror. See, if you just pull the flap, if towards the center, and in a ripping force, usually you have to hold at the edge. Whereas in this, if you just pull it, the rexis will become smaller. I just don't want to go depth in that part. This is what basically you have to think of shearing and the ripping forces like. Yeah, just see this video. Just focus on this. Here, again, the same technique I have been following like. I just went to 2 mm. Suddenly there is a jerk there. So initially I was following a shearing. If I just applied more, that will extend it like. So be careful while doing an rexis, where sometimes this may cause a bit of problem like.
So if by chance it's not a complicated case, okay? Let's say it's a clear-cut case and when you're doing your rexis. At any point you feel it is going to the periphery, that means you're putting more pressure while you're pushing the capsule. Keep that in mind. That means you have to immediately reduce the force you're applying and then slowly start moving. So that you have to keep in mind. That is provided it's a normal case. There are other cases where it has a tendency to move away. That's different. But in normal cases, do not. That means you are putting extra force. Keep that in mind.
What are the basic instruments used to make a capsular rexis? Obviously, we know that it is a cystitome. Then comes the utrata forceps, then the micro forceps, and the femto such like. How to make a perfect capsular rexis? Number 1, first and foremost thing, maintain the AC depth. This is very important. Like that will be compensated by the viscoelastic in the anterior chamber, which counters the vitreous pressure, and at the same time it relieves the stresses over the zonule slide. Just focus on the picture as such like. Secondly, the centration. Centration, see, we can focus on the first Parkinson's image, start from there, and if the facilities are available like Callisto or nothing like that, automatically the centration can be utilized there, and we can easily done the centration part like. Thirdly is the sizing. Sizing is usually very important. Why in the sense means, if you just 1 millimeter of smaller to the optic size, so that there is 1 millimeter overlapping of the IOL. So optic overlapping of the IOL optic, that gives a shrink wrap effect where that IOL doesn't pop it out. Then doing a complete inverse like. So whenever you are doing, this is the courtesy by NSR like, see, whenever you are doing a rexis, at the last portion, the last pull of the rexis should be directed inwards. Then ensure that the rexis is complete and there is no tags. Just focus on this. Focus on the video. See, that is the technique where at the last portion, you just pull it inside the tag that should be forward, projecting towards inside. Okay, what happened if there is a complications when you come across the complication part line? What are the complications you come across? Number one, the rexis run over. Whenever there is a rexis run over, what are the reason for it? Number one, it is an eye intralenticular pressure. And the two is the poor technique what you have been following. The third is the zonular weakness. Fourth is the pediatric and also in an young patient. If the rexis run over, you can follow the what is called as a little maneuvers technique like, where just put the visco there, hold it with the forceps, drag it towards the center. If it comes, well and good, or just leave it. Do a reverse capsule or rexis, and you can finish the Phaco as you are comfortable, or you can convert into SICS. This is the one, once again, the video where the rexis has run over. Just see there. I have decompressed it like, started doing a rexis. When I am completing almost 3/4 of the rexis, suddenly there was more of an intralenticular pressure. I tried to pull, I used what is called as a ripping force to pull it towards the center. It was really difficult. Then I have to go for a higher molecular weight visco. There is a runoff. In this portion, in this time, basically stop it.
So what do you think went wrong when you saw that case? No? So what do you feel, anybody has anything that, where it went wrong and it started running away? Any? Okay. Anything else? Could you, yes. Could you come to just that spot where it started extending? Just forward it a little bit, please. So now you have to see the force at which he was trying to pull it towards the center. So if you realize how to pull a technique, pull a rexis which is running away, is first you start pulling in the opposite direction, right? And then once you have a stretch, now see now, just hold on. Now look at the direction. And that's it. So actually what should have been is, if at all you're feeling it's extending, don't try it from the same side, because you can't do that technique of pulling it towards, because it is just under the side port. That is the most challenging part. So what we need to do is change hands, hold the same place, pull it on the opposite side where you were trying your rexis, in the same plane of the capsule. Once you have a stretch, then pull it towards the center. Then it will just come back. So this is something that we need to. Yes, please. Oh, yes. So if you see the point where he went off, because it was the wrong direction, he felt it was running away a little, he filled in visco. Then he started just pushing inwards. So that will extend if there is interlenticular pressure. You can't just go inwards. And it was inwards and up. So the technique is, if it's running away, you have to pull it on the opposite side, in the sense that in the direction you have already finished. You have to hold it. No, not forwards first. First, you need to stretch it against it, against the direction. He'll show you the technique, how you're actually doing it. Again, he'll explain that. So once he's explaining that, then you'll realize what went wrong here, because it went in the other way. So if you're in the same side port, if you try it, you cannot do that maneuver at all. It's not possible. So you need to interchange, hold the capsule, and he'll explain the direction on exactly how it needs to be built. He'll show you the images, and then it'll be much easier.
And this automatically I have to go in the other way around. I have to go in the opposite direction, finish the rexes. I was comfortable in doing the Phaco and implanted the lens. Here, implanting an IOL, whatever the haptic portion should be perpendicular to the runover portion. That's you have to think. If you should not put an haptic where at the runover portion, it should be exactly perpendicular to that. Now coming to the fibrous part.
So can you come back to the images behind?
Behind, sir?
Slide. Go to the previous slide. Previous.
The video slides.
Yeah, before the video. Before this. Yes. So this is the technique, okay? See, now you can see the left top image. So that's the A, B, C, D, correct? So A part is where it's running off. B is next. Now hold that running off part, pull it towards the side you have already traveled. Okay, they should be at the capsule plane. Have a stretch. There should be a stretch. Then once you have the stretch, you pull it inwards. That's when it will come back. Without the stretch, you can't pull inwards. If you pull inwards, it will go out. Okay? Next, please. Is it clear? Simple, no?
Now coming to the fibrous part, the complications. What do you mean by a wrinkling? Wrinkling is a sign of weak zonules. The tips to remember is direction of pull should be from the centropetally, number one. Secondly, always start away from the weak area. These are the 2 points you should be very careful whenever you see a fibrous or a wrinkling as such. Like, I'll just show a video one. This is the one video. Just focus on this video. Like here, I just manipulated and there was an phacodonesis, like means there was a zonular dehiscence. Just with the help of an 26 gauge needle, I just put a small nick. With the help of an forceps, I completed the rexes. Beautifully, the rexes went well. And as usually, I just did a Phaco. After the Phaco emulsification, I inserted an CTR and implanted an IOL as such. Like this is the one in case of a wrinkling, and especially in a fibrosed. In a fibrous part, just focus there. Always, whenever you see a fibrosed in one particular quadrant, try to start from the distal, that is away. Start the rexis from there, complete it until you reaches to that point. Then with the help of a micro scissor through the side port, see, this is what I have been doing. Like I am feeling difficulty here. Like through the help of a side port, I entered there with the micro scissor. I just incise, but again the incise part is very important. Don't cut in such a way that rexis should be multiple tag as such. Like in the sense, you should be clear that it should be inside the rexis portion, then drag it out, then complete your rexis as such. This is the one thing where I just want to show in the fibrous part. Like.
So when we say that, okay, now let's say you have found zonular weakness inferiorly, okay? So where should you put the nick first? On the opposite side, superior? Okay. Now why is that so? Why not do inferior? It's the same. That's because, let's say if you do superior, all your movement will be towards, you will be trying to pull the capsule towards it. But you need a counter traction, because when you're pulling something, if there is no counter traction to it, whole lens complex will move. Now let's say if I've started inferior, I start pulling the capsule to open the flap. If I start doing this, because there's no zonules pulling it against my action, it will move. So you'll be struggling and struggling, and you'll break more zonules, and by the time you finish, it's gone. But if you have more zonular weakness, what you can do is make a small nick, open slightly, put a capsular hook. At let's say 2 clock hours you finish, put a capsular hook. So that is doing the counter traction. Then you increase the flap, then put one more capsular hook, and then complete it like that. That's also one way when it is very challenging to even do that, so that you don't damage the zonules further. Okay?
Thanks.
Done? I think
Just another 2, 3. Finish. Okay. In a case of a small rhexis, what are the problem can arise in a case of a small rhexis? There will be a damage to the capsule during chopping, difficulty in removing the subincisional cortex. There is an increased risk of anterior capsule contracture and phimosis. There will be difficulty in implanting the IOL in the back. This is what called as a spiral rhexis. Means, what do you mean that spiral rhexis? Do a small rhexis initially, then again you do as a double rhexis like. Rhexis completed in 2 passes. First made a small rhexis, then extended to the appropriate size. Advantages is provided more controlled environment. It is quicker, reduce the risk of a runoff as such like. This is a video I just want to show. I did a small rhexis and I completed the rest with the spiral rhexis part line.
So how do we prevent, if you have a small rhexis also, how do you prevent from nicking the capsule or your rhexis? So one way is to create a pattern, okay? Our pattern of chopping is, we impale, hold, take the chopper or dialer, do this, separate, correct? So don't do that. So once you've got a hold with the Phaco probe, don't start like this. First start from the center, touch the capsule, not the capsule, sorry, the cortical matters, go to the periphery, then chop. So that means your tip is always in the right plane. No matter where your rhexis is, it's always, if you create this kind of a pattern every time, you create muscle memory. So no matter what size of rhexis you have, you'll never hit it. So even if you don't visualize it, you are safe.
Then what are the 2 stages of capsular rhexis? Whenever you feel it's a very intermittent big nucleus, do a needle puncture on the anterior lens capsule, do a mini capsular rhexis, decompression of the posterior compartment, cutting the edge by just a radial cut. I'll just show a video that as such like, and to complete the rhexis part like. This is the one last on the 2 video slides are there. In a case of an intermittent, what are the problem we are facing as such like? Number 1, the fragile capsule will be there. The liquefied cortex egresses out because you can't able to do the rhexis perfectly, and the visibility will be poor. And there is an increased risk of an extension and then Argentina flaxine like. There is a raised intraocular pressure also like. This is the one video as I just want to show where all the technique we can, first of all, whenever you are operating in a case of an intermittent, number 1, follow a soft shell technique, use a double visco part, dispersive, then the cohesive later on. Put a small nick there, decompress, remove the liquid, whatever the liquid is there. Thirdly, do a small rhexis. Complete the rhexis like. This is the spiral part as such like, and the fourthly, I do what is called as a small nick radially. That's important like. Then ultimately you can complete whatever the size you want. Basically we need around 5 to 5.2, 5 to 5.5 mm. Complete the rhexis, then whatever the technique you are following as such like, you finish the Phaco. Techniques of capsular rhexis in an intermittent. Number 1, as I told you, soft shell technique. Number 2, needle decompression, Phaco capsulotomy. number 3 is the YAG anterior capsulotomy. Here, I have, prior to surgery, I have done a small nick with a YAG cap. Just see there is a rag in the center part of the anterior lens capsule. Comfortably finished the rhexis. There was no run over, there was no tag, no problem or the run over as such like. There is no issues at all. There is no lenticular pressure because of whatever the fluid was there is already came out from the lenticular part, which is in the AC as such like.
Dr. Venkatesh, can we just move forward to the YAG one and then we'll
Back,
go
sir?
to the YAG.
Back.
YAG.
Back.
This is post-YAG, huh?
Yes, sir, post-YAG, sir.
Super.
Go
So
back.
this is a non-contact one. So what we do is, on the day of surgery, you do a YAG in the center.
Go back.
So it reduces the interlenticular pressure.
Yeah.
So this is 100%, you won't get a Argentina flag sign. 100%. There's no doubt on it. But it doesn't mean that it cannot run off to the side. So you still have to be careful, you still have to take care. But Argentina flag sign is 100% you can avoid with this technique. Okay? Shall we?
Yes, sir. Single shot, finish it.
I think we are
Yes.
short.
Thank you.
Thank you so much, sir. I think you wonderfully covered all how to get that perfect rhexis. Everything that a phaco surgeon wants the next day is to see that clear cornea. So I would like to call upon Dr. Naren to give us pearls to get a clear cornea on POD1.
Remove kardala. Just remove kar dalo.
Okay.
Just take it out. Wait, I'll just take it.
So one of the things, I think each one of us want a nice clear cornea the next day, right? Can we turn on the mic at least? Mic. Mic, please. No, it's not. Okay, super. All right. So the first thing is to be prepared, okay? And the patients need to have more realistic expectations. So we need to make sure any risk factor for a cornea to be, edematous the next day, you need to keep in mind like shallow AC, or you have already a compromised endothelium, NS4, and so on and so forth. It's good to document it, and you need to counsel the patient before the patient goes for the surgery itself, all right? Now let's look at the first aspect, epithelial edema. Now, when can this happen? Is when the pressure builds up. And when pressure builds up is some retained viscoelastic. So one of the small trick in washing of viscoelastic is, if you see the irrigation cannula, I use the irrigation from the side port, direct the holes superiorly, and you can see those bubbles disappearing. Let me show you again. Can you see it? I'm not using my aspiration, I'm using my irrigation. Always remember, never take your aspiration close to the endothelium. Then you see, I take the irrigation again, below the lens, clear the visco, and then put it back, okay? This is all when I'm in step 2. I never take my aspiration below. That's very risky, and you will end up with a PCR. So please avoid that. Always move your irrigation than your aspiration. It's something like taking a vacuum. Let's say there's dirt all over here. Is it easier to wash off with the vacuum cleaner, or is it easier to wash off with a pipe? Any answers? Pipe, no? So irrigation cannula is the best way to wash. Next is wound edema. So wound edema occurs whenever we construct a very long main port, right? What happens is when you create a very long main port is, the irrigation ports now and then or most of the time is hydrating the main port. And then over time you add this hydration to close the wound, again you hydrate, so the whole wound edema extends almost to the center. So that is something that we need to avoid. Make sure you taper the tip exposure in the right amount so that your irrigation ports are within the chamber. So it's very important. And don't overhydrate. Don't hydrate in such a way that you're going to wash off the whole cornea out of the eye. So please be very careful and gentle. And if you're having cases where sometimes I hydrate, the DM detaches. If you have some cases like that, don't hydrate towards the cornea. Let's say if there's a wound like this is towards the center of the cornea, this is towards the limbus. Always hydrate towards the limbus part of the wound, okay? So that part of the wound is not very close to the DM. So there's a less likely of you causing a DM detachment. Now coming to the main thing is corneal edema. How do we protect the endothelium? Now in regular cases, I think you can use, most of us use HPMC. Definitely Viscoat is very expensive. But if you have it, use it. It's fantastic. It protects well. But if you're using your HPMC, one trick is before you start your Phaco, we have a tendency just, okay, I finished hydro, I take my Phaco probe and go inside. No. Fill the chamber with viscoelastic. And then you start. All right? The next step is after you finish chopping all the pieces, don't eat your quadrants before that. Finish chopping all your pieces first. And then you can come out, put viscoelastic again, and then eat up. Because the most important part where the endothelium gets damaged is when you're doing your quadrant removal. It's not the energy that you deliver into the lens while you're trying to chop. It has no, even if your CD is 100 or something also, nothing will happen because all the energy is gone into the lens. It is the time when you bring it up and start eating the pieces, that's when everything gets damaged. So again, before quadrant removal, you need to put viscoelastic, and then soft shell technique is very, very important. You put a viscoat on the top. Basically, what you have to do is make sure it's like something like painting. You keep injecting the viscoat little on the higher side. Once you inject it all over, below in the center, start injecting the regular. If you want HPMC also is fine. Regularly, actually, you're supposed to use, I would say, a cohesive. But I prefer an HPMC being injected in the center. That should be more than enough. So this will make sure that it is protected. And refill every 15 minutes. Anytime you're finding there is chattering of the piece, stop. Don't keep continuing. You stop, you see you can rotate your Phaco probe a little bit right and left. Then you try to Phaco so that the chattering stops, because the more it chatters, you're again and again damaging the endothelium, all right? So when you do your quadrant removal, okay, I personally always remove my second hand piece. Now what this is, it's, why I do this is, one is to stop the leak. Now if you look at this part of this, you can see some amount of fluid coming out, right? So when the fluid is coming out, that means there are two ways the fluid is getting out of the eye. One is through the side port and one is through the Phaco probe, correct? So this leads to, the lens sometimes goes right and left and leads to chattering, and then it leads to some amount of endothelial damage. And it doesn't create, that much. But if you look at now, once I've removed it, there's no fluid coming out of it. So it creates a better fluidics within the chamber, and that way your phacoemulsification also is very effective. Now when you're removing your piece, okay, your quadrant removal, there are some few things you have to do. The Phaco tip should be in the center, okay? Again, Phaco tip should be in the center. It should be at the iris plane. And you should press step 3 only when necessary. Even if there's no piece, people just keep pressing 3, which is not good. Just be always aware. If the tip is not occluded, do not press 3. If the piece is somewhere else, you're still pressing 3, then you'll end up damaging it, okay? And do not move the tip when you press step 3. So when you press step 3, you shouldn't keep shaking your Phaco probe. So that means, there's a high chance of the PCR or other things happening. So please don't do that. Now I'll just show you how it is. So you can see me, I've brought it to the center, and then only when I'm in the center, I press step 3. See how quickly everything disappears. I know I use a little very high settings. We don't need to use these high settings. But the point is, I use it only because I want the pieces to come to me rather than me go close to the PC or go after the piece. So I'm always in the safe plane, and that way I protect the endothelium and prevent complications. Now, between high flow and low flow settings, there is no statistically any difference in terms of endothelial protection. There is a study where they've shown that pre-op high-dose pulse steroids, that is every 15 minutes, 2 hours before surgery, it reduces the inflammation, corneal edema, and macular edema. This is something, I mean, we don't use it, but the data have shown that, that it does help, and definitely you can try. Now, I want to share more on how do we prevent a PCR also, because PCR, once a PCR happens, complication happens, then when you handle the complication itself can damage the endothelium. So it's best to avoid it. So I'll just share a few tips and tricks. Whenever we do divide and conquer, please always start from proximal to center. Never, we have a habit of starting from the center and pushing to the nasal. Let's say if I'm starting from here, I'm sitting temporal, I start from the center and push it nasal. Do not do that. That's a very bad idea, and you will end up with a PCR. Always start proximal, go to the center, stop. Never look for glow. Oh, I've got a glow. Oh, that's the right plane. No, that means you're already too late if the glow is too good. Okay. So now, if you look at the fibers, now I'll just show you the trench. Now, can you see these fibers here? You can see, no? Can you? Yeah. See, now it is perpendicular to the trench, correct? Right? Now, as I go to the right plane, let me show you. Now, you see the fibers? It's going along the trench. So if the fibers go along the trench, that means you have reached the right depth. So stop looking for glow. Okay, you will see darkness. Anyway, so moving forward is quadrant removal is, I think, one more small thing. Let's say I have separated all my pieces. Now my aim is to bring the piece to the center and emulsify, right? Now, how do I avoid it? You shouldn't, when I go close to the piece to hold it, you should not press maximum 3. You're not trying to emulsify in that area. You just want to hold. No, it should just be a tinge of 3 and come back to 2. All right? Everyone knows 1, 2, 3, right? 1 is irrigation, 2 is aspiration, 3 is power. Okay? Keep that in mind. Now, the next thing is avoid pushing the piece. So if the piece is here, avoid with the Phaco probe to push like this and then try to hold and bring it to the center. That's very, very dangerous. Why is that dangerous? I'll just show you an example. Never try to push like this and then press the 3-2 and then bring it to the center. You will end up with a PCR. So what you need to do is, I'll just show you here. So what you need to do is you should just touch, not push. See now, look at me, just touch, 3-2 and brought it to the center. That's how you bring the pieces safely to the center. So whenever you do push it, what happens is your plane eventually will be very close to the posterior capsule, and when you put the power there, that's when the PCR happens. So please avoid that. Then I think the rest of it is in extreme cases like this where you have +4 and a lot of gut and so on and so forth. Counseling is very important. Pre-op, the high-dose pulse steroids work well, and soft shell technique, visco every 15 minutes, in the bag Phaco, or you need to Phaco at the iris plane. Remove the second hand piece when you're doing your quadrant removal. Monofocal always in these kind of cases. Leave the patient a little myopic so that if at all the patient requires secondary procedure later on, it'll compensate for it. And make sure you remove all viscoelastic, because already the endothelium is weak. You don't want it to pump and struggle post-surgery. So if you ask me one thing, forget about all these stories and everything. If you tell me, Doc, tell me one thing which is the most important step to have a clear cornea is, any guesses? Sorry? Visco? Yes, the plane of surgery. It is so important. In fact, if you do your surgery in the right plane, even the most compromised corneas, even with Gutte, you can just, with HPMC, you can get away. And you won't guess. And I would say is, the next day you should always make a mistake of saying, is this the right eye or left eye? So actually the compliment which I got, I don't know whether it was by mistake, when I felt, okay, is one of my teacher, he was in the OPD, I was standing with him, so I had operated the previous day. And so he saw the eye, and then he looked at me, see, this is how the case should be. You should not know whether it is the right eye or left eye surgery and all. Then, so this is how I see my case and all, he said. So then I said, actually, sir, that's my case. So I mean, I'm not trying to boast, but it's a nice feeling, but patients get very angry. Yeah? So always my trick of saying this is, I say, I'll be seeing both your eyes. Don't worry, I'll see both your eyes, and then I start seeing. Otherwise, patients say, doctor, you don't know which eye you operated, what man, and all that. But anyway, thank you so much.
Do we have any questions for Dr. Naren? Anybody from the audience? Okay. So I'd like to call upon Dr. Aishwarya, who is going to take us through managing one of the toughest grade of cataract. Those are soft cataracts. So please take us through pearls of managing a soft cataract.
Thank you, Dr. Tejal. So good afternoon, everyone. It's very nice to see a full hall over here. So I'll talk about why we emphasize on soft cataracts. The problem is that over here, we are looking at more awareness in patients who are presenting early to us. They have problems in driving. That is normally the first problem that they come with, and more expectations because they think that if you can do a cataract surgery, can you please help us from removing the reading glasses? Now the issue over here is that we have to identify a soft cataract, anticipate a soft cataract if the patient is young. Then you have to talk about having a lens opacification system where you should be able to say that yes, you have cataract, and that is the reason probably at the age of 25 that you are undergoing this problem of not being able to drive properly. And look at something which is known as the DLI score. The DLI score comes on eye trace, and often a lot it has saved us from embarrassments where patients were told that, okay, because of the DLI score which is going towards red, and although it is not showing a lot of changes, this is the reason that you are having difficulty in doing your day-to-day stuff. Now coming to challenges of soft cataract, we all have encountered fishbowl, we all have encountered PCRs, difficulty in holding nucleus, cheese wiring, and difficulty in rotation. Now these problems can be understood better if we look at the videos now. So I'll just show you the problems and the solutions. Coming to capsulorhexis, we have a very elastic nature of anterior capsule. And please remember that, like Dr. Venkatesh said, that use a ripping force instead of shearing force. Stain the anterior capsule with trypan blue dye and make a slightly larger capsulorhexis. Why? I'll show you. Because if there is a larger rhexis, you can actually have a good overlapping of the IOL to overlap a 6 mm optic. You can have hydroprolapse. That's one of my favorite techniques to do it. And also it allows for optic capture just in case if you've had a rent. Hydro procedures. We know that the conventional hydrodissection, cortical cleaving hydrodissection, hydrodelineation, and hydro-free dissection, all these 4 techniques should be a part of our armamentarium. No matter what comes, all of us can use all these 4 techniques instead of using only hydrodissection as a part of your armamentarium. The problem of cheese wiring and gelatinous endonucleus attached to the capsule by thick condensations of cortex can be countered with a good cortical cleavage hydrodissection and minimal rotation to avoid cheese wiring, but ensure one good rotation so that you know that you are in the correct plane for doing the surgery. Now look at this particular video. Over here I am doing hydroprolapse of the nucleus. This is my favorite technique because I feel that I can finish off the surgery faster and very safely. Now once the rhexis is done, I ensure a good hydrodissection, and just look at this. The nucleus has just popped out. Although you will be having a slightly shallower AC, but at the same time, once the nucleus is flipped out, and since it is a soft nucleus, you have a lot of space to move around, and you have been able to emulsify the nucleus in a safe zone. Now, when I talk about multiple hydro procedures, just look at this particular video where we are ensuring a good rhexis with a good glow. Good glow and a stable anterior chamber are very, very important for this particular techniques. Now look at this. I've done multiple hydro procedures. I've done basically 2 golden ring reflexes that you can see. This helps me to emulsify faster and also helps me to emulsify in a safer manner, and it also reduces the amount of bulk that I have to remove during my irrigation aspiration. Now coming to nucleus management, we are talking about endocapsular techniques and supracapsular techniques. Like Dr. Nareen mentioned, supracapsular techniques can be slightly tricky. It is better to probably more tend towards endocapsular techniques. For example, modified stop and chop, chip and flip, bowl and snail, and mechanical chop. Now here, when we are looking at modified stop and chop, this video is courtesy Dr. Rohita ma'am. So over here, a central trench is being made, ensuring that you have a very good anterior chamber. The trench has to be end to end, but at the same time, making sure that the division happens with the help of your second instrument and the first instrument both. So just go there. The division has happened. And now a quick rotation. And with this, if you can look at the center, just like how we have just spoken about the fiber orientation, getting a good purchase is very important. And once it is done, you can just see this, that the doctor is able to take out the first half easily without even having to go for a direct chop or any other chopping techniques. Now this is a modified stop and chop technique. And over here, even for the other portion, once the rotation is happening, a good rotation and hooking the nucleus by the shoulder, taking it out. So this technique is a very good technique if you like doing stop and chop, and also in different situations where you may have a central nucleus which is very soft but still a little more fibrous peripheral cortex. Now coming to the chip and flip technique, this is again by Dr. Rohita. Just have a look at this. After ensuring the good side ports and a good main port, you can see the cortical cataract is more towards the nasal side of the doctor because the doctor is sitting temporarily. A good rhexis. And then a good hydrodissection. Please remember, if the cortical cataract is away from you, try to do hydrodissection in areas where the cortical cataract is not present, so that you can actually have a good purchase, and at the same time, if at all there is a lot of fibrosis, you can prevent a PCR. Now with this, again, the central nucleus is already taken out. The endonucleus is taken out. It is basically like making a bowl, especially making a bowl. But at the same time, going nasally, just see how the nucleus is actually coming out on its own. But at the same time, the purchase is towards the front, that is towards the nasal side, and then you are able to emulsify the nucleus. Now coming to the bowl and snail method, this is a flax related patient where the flax was already done. Now ensuring the hydrodissection is done at a plane where it becomes easier for us to remove the cortical matter, and also a sheet of cortex has been taken out already with the help of hydrodissection cannula. And then the emulsification can happen at a good pace. Now with this, I think we'll just move on to the mechanical chop technique. Now, mechanical chop technique, this video was given to us by Dr. Venkatesh sir. Here what is important is to remember something, that the no phaco power is going to be used when you are about to dissect the nucleus. It's very easy, just go ahead, make a rhexis and go ahead with the hydrodissection cannula. Once make sure that the nucleus's rotation is present. Don't hold the nucleus at any number, like not at 1, 2 or 3, just keep the irrigation on, and then you can simply divide the nucleus with the help of your phaco probe, just as a hook over there to hold the nucleus, that's all. A good hydrodissection over here, and then once a phaco probe is put, I think I cannot emphasize more upon the fact that you have a golden ring reflex every time when we are doing soft cataracts, because that is one of the main things which helps us in doing our surgeries. Just have a look at this. He's just holding it and he's just cracking it into 4 pieces over here. Now this is one of the techniques where we are doing a direct chop.
So what we need to do is, now if at all you're doing mechanical chop, the meaning mechanical chop is we're not using or going to step 2 or step 3. We are doing it under irrigation itself. Yes. Okay. Now what you need to remember is the dialer that you use, the tip should be little long. It should look like a chopper but not a chopper. Okay, the tip should be blunt. Now the technique, how is, you should take the phaco probe, just impale. You don't need to, I would say either you can do like a stop and chop also. You can just do a small trench and then hold it in that place and do it also. Or what you can do is just place it in the center, right? 45 degrees. You're in the center of the lens. You don't need to press, because if it's soft, then you don't need to use even vacuum also. You can reach the center. You just be in the center, hold. Use a 45-degree tip whenever you're doing this, and use a 45 degrees to your right. Face it to the right. So it acts like a hand, right? It acts like a hand to push this part away. Now what you need to do with the dialer is do a long chop. That means keep enough distance from the phaco tip, go deep towards the tip, and then slow sideways. Okay? I'll repeat it again. Long, start from far, quick chop towards the tip, but it should be deep, and then slow sideways. Slow means really slow. Just wait, separate, slow, separate, wait, like that. So this, 100% you will get a chop, even the softest of the cataracts. So that you need to remember. See, there are many ways to skin the cat. I don't know why that phrase came, why someone has such a bad thing with cats, but the whole point is you need to stick to one technique, and I mean you can try everything, but stick to one and repeat. And that's when you become very good at that technique. But every time you touch the lens, you're trying some new stuff, then you'll end up not perfecting anything. So that you need to remember. I personally always do a mechanical chop. The second what I do is, I think maybe you can.
Yes, I have this. So this is also one of the techniques that we can use. That is the rapid technique, where you can have a rotation, alignment, and impaling, placement of the nucleus, and impaling and devouring the nucleus. Now this is one of the techniques where if I have a slightly harder cataract, that is around grade 1 with NS1 PSC, and that is where we would like to go ahead and do the chopping over here, like a single chop, impale in the center, and then just align it, place it, and impale the nucleus over here and devour the nucleus. Now I'll talk about here on the small pupil technique.
I think you can skip the small pupil.
Yes,
go to
sir.
the next. Yeah.
Posterior polar catney. And this is also a soft mature cataract over here. And over here, the looks can be deceptive. You have a mature cataract with no glow and sometimes can be a soft mature. and difficulty in attaining good chops due to cheese wiring. But over here, what's important is that slowly you have to be very careful in dealing with the soft cataract while you are using a mature cataract. Now over here we have epinucleus management, where you can have a carousel technique, a zero power vacuum, low vacuum technique, and a viscoprolapse technique, where it is important to have inadherent hydrodelineation which may leave thick epinuclear plate behind, where taking out the nucleus becomes easier if you can chop in the center and then use the side areas to take out the nucleus.
Can you go to the last?
Yes, sir. So this is getting stuck here.
No, that's fine. Don't worry.
So we can talk about the smile technique, sir?
No, that's fine. I think
Yes, sir.
maybe if time
I
permits
have-
at the
yes.
end, I can
Yes,
show
sir.
it.
You'll
I'll
show
show
it,
it.
sir.
Yeah, that's
Okay.
okay. Don't worry. It's done, right?
Yeah. So we have this 10 pearls and soft cataract. I think we will probably go ahead with this 4 things to remember: that a good sized capsulorhexis, a good cortical cleavage hydrodissection, a minimal rotation to avoid cheese wiring, lower settings in terms of power, AFR and vacuum. Then remember that no size fits all. We should be familiar with a lot of things and a lot of techniques to apply the one which fits the case best. Use adequate protection of endothelium. And for epinucleus removal, the carousel technique and viscoprolapse can be tried. And then with cortex removal can be challenging due to sticky nature of soft cataract. Along with that, early onset PCO is frequent in younger patients. So that is why meticulous capsular bag cleaning should be done. And at the same time, flax, if available, ensures a safer surgery with good visual outcomes. Thank you.
Perfect. So one point I wanted to bring about is, now we have a tendency that, okay, it's a soft cataract, let me reduce my vacuum and flow, correct? That's what we get. But why should you do it? Can you actually chop using vacuum and flow in soft? Anyway you can't, then why do you want to manipulate that? Leave it alone, because anyway you're going to do a manual chopping. You're going to only use irrigation and chop. After you're finished chop, if your vacuum and flow is low, what's going to happen is you'll hold, release, then finally there'll be a thin plate. You'll end up going so close, you'll end up with a PCR. So don't do that. So what you need to do is keep the settings high itself, the flow and this, so that if you just touch it, tuck until the piece will come to you, and then you'll finish off the case quickly. And you're operating, it's not that, oh no, the flow is high, that's why I'll get a PCR. No, not really. If by chance, according to your, depends on the capacity of the machine, whatever you feel like it's high enough that the machine's able to compensate, be able to handle without a surge, then use that settings. That's important, because every machine behaves a little differently. You have to make sure there's no surge and then operate. All right? Perfect. Thank you.
Thank you so much. Now that we've discussed about soft cataract, we go to the extreme of it, management of a brown cataract by Dr. Rohita.
Good evening, everyone. It's good to see all of them here, even at this, when the topic is ending.
Which hall is that?
Hard cataract.
I see. I'll still go. What is the hard?
Hard cataract. I shall just talk on how to manage brown cataracts. In view of time, I think I'll just skip to the Phaco part rather than for any surgery, for a good outcome, the process has to start preoperatively. A good specular microscope is required to know the status of the cornea, and a thorough retinal examination needs to be done. Yeah. Achieving accurate biometry is difficult with dense brown cataracts, and in these kind of cases, Argos can help us because it has a enhanced retinal visualization mode where it can even penetrate through hard cataracts. The preoperative planning, that is, you have to explain the condition to the patient and explain that the surgical duration may be prolonged and the possible need of converting the case, and the recovery can be prolonged. Coming to the surgical steps. The need of tryptophan blue because the glow is not adequate is very important, and it is better to aim for a little larger axis rather than a smaller axis. In these cases, we have to remember that it is always better to do a gentle hydrodissection in multiple planes rather than just trying to do it from one corner. What happens is when you send a wave of fluid, the intralenticular pressure increases, and if you keep doing it, you may have a PCR. So gentle hydrodissection, the moment you see that the AC is slightly shallowed, you know that you have done a good hydrodissection. Avoid vigorous rotation, because in brown cataracts, because of the heavy nucleus, the zonules are already stressed. And using a Ashenov's soft shell technique is of prime importance in these kind of cases. It is always better to use a dispersive visco like a viscoat initially to coat the endothelium, and then HPMC in the second place. And you can also give a little bit of BSS just above the area of rexis, because there is a lot of heat generation when you are actually doing a phaco. So it is better to have these three. It's called a tri-soft shell technique. Now let us understand the opponent here. We have a very hard nuclear core. We have a leathery posterior plate, and we have associated zonulopathy. There are three main problems we are going to face. And how do we get a perfect chop? The problem is getting a deep chop. If you are trying to engage the central core of the nucleus first, which is the most hardest part of the nucleus, you may not get a complete chop. So it is always better, and we always need excessive force to divide this. And we will also weaken the zonules in trying to do all these things.
I'm coming, sir, coming.
And it is always better to do something called a flower petal pattern, where you can do a peripheral chops. And you isolate the central core of the nucleus and then eat up that part.
So if you look at, can you show me the, yeah. So you see the shape of the lens, right? It's like an onion. So the superficial fibers, if you follow it all around the equator, goes back, and finally, actually it is the posterior plate. So what is the most difficult part to chop in a hard cataract? The posterior plate, no? And also the center, which is very, very hard. Now, if you imagine this is the cataract, it's a brown-black cataract. What is easier to chop, the superficial or the center? Superficial, right? So we have been always taught that, look, oh, hard cataract, you have to do a nice deep chop and then separate it. Actually, you should not do that. You should do only a superficial chop. And then when you separate it, the separation will start from the mid-periphery, then go to the equator, go down and separate the posterior plate, leaving the central nucleus behind. So once you do this, you don't have to apply so much force and struggle to separate the hardest part of the lens, but separate the easiest part of the lens, right? And for soft cataract, any guesses? Should you chop deep or superficial? Deep, because there you want to hold the hardest part, because most of it is soft. So you should be in the deep, in the center. Here, you can just be in the superficial area, that's more than enough, and automatically your posterior plate gets separated, and it's very, very easy. Please.
And we can do a superficial chop because even the superior fibers are also very dense. So your hold will be good even if you are holding it superficially. So due to the increased density of the lens, the hold is good even if you are in the superficial area, and it will have less stress on those zonules, and it will isolate the central nucleus core. Now coming to the length of the chops, like whether you want to have a very short length of the chop or very long length. So what is the problem with having a long chop? Like you can hold and you're trying to come from there to here. So you will see that your nucleus is slipping from your hand. You're seeing that. There's a tendency to rotate is more when you're trying to do a long chop. It is always better to do a short and swift chop. It is always better to just lift the nucleus when you're chopping. Me-loop can also be used, and the safe emulsifying strategy is the level of emulsification. I think we have spoken about this, that when the piece is emulsified within the bag and your aspiration flow rate is higher and you're thinking it's a hard cataract and you have kept your vacuum high, so you'll see that the PC is trying to come and hit the probe. So emulsification should always be at the level of iris, provided that you have coated your endothelium. Coming to the main thing, that's the settings. So for chop, we can see that your IP should be off, and you can keep your vacuum and aspiration flow rate at a higher rate itself. And in for quad mode, your IP should always be on. That is, you can keep the torsional to 100, but you keep a small amount of longitudinal phaco remaining, so that if the phaco probe is blocked, occluded completely, it is not going to do anything even if you are in phaco 3. It will just give a jackhammer effect. It will give that small longitudinal burst and it will dislodge the piece from the phaco probe, so you'll be able to catch hold of it again. In Centurion, you have something called active sentry. So it always keeps sensing the intraocular pressure inside the eye, and you'll have a maintained chamber. If you want to do phaco in with low IOP, so when you're in trying to do a phaco with low IOP setting, we have to keep three things in right, the vacuum rise. Vacuum rise has to be 0. That is the amount of time taken for the vacuum to build up the moment you have touched on the probe. And IOP ramp. IOP ramp is the time taken for the IOP to build up inside the eye. So you keep it fast. If you go back and see, it will be around 1.2 in your settings. So you keep it fast. And the irrigation factor. Irrigation factor is the amount of time the fluid takes to come inside. So that also has to be faster if you want to operate with low IOP settings. So here I am operating a hard brown NS5 cataract. Use of tryphan blue is mandatory in these kind of cases. A good 5.5 to 5 mm rexis and a gentle hydrodissection. You can see the wave passing. Just tap it from the other side so that you are not building the intralenticular pressure. This is the customized, it's actually a dialer, it's not a chopper. Okay, coming to the tip exposure. Here it's always better to keep the tip exposed a little longer so that you have a better hold. And how to achieve a perfect chop with 3 steps. So I'll show that in slow motion. Superficial embedding of the phaco probe first. Then you do a short chop. Try to separate and go multi-level. Go again. Embed the nucleus again and chop. So superficial embedding of the phaco probe, short chop and multi-level chopping. You will get a clean cut, only peripheral. And keep repeating this at least 6 to 8 times so that you have 6 to 8 small pieces. Then I remove the chopper, second instrument, and you can see that the central core is separated. When you take out the second instrument, the chamber is well formed. And the care continues even in the post-operative period where it may require a prolonged course of steroids. Thank you.
Thank you, madam. It was really an excellent one. Like now I call upon Dr. Tejal. Now the topic is management of the PCR. Over to you, madam.
Okay, now that they've discussed about making, Phaco easy by management of a soft cataract, hard cataract, and you still have a PCR, how do you manage that is something that I'll be dealing with today. The first important thing is how do you recognize that there is a rent? There are simple things that, the eye gives away itself, like a pupil snap sign, the AC can deepen suddenly, there can be striae on your posterior capsule, or the red reflex suddenly becomes even more clear. The nucleus, which was freely mobile, becomes difficult. You can see the lens tilting or also vitreous in AC. So these are the signs that, there is PCR in the eye. So what are the important steps? So if you start with the wound construction itself, make sure that the wound is always a clear square shape. And it is not too peripheral. So if there is peripheral, the sealing itself becomes difficult, and that itself can cause a difficulty in managing every step of your phacoemulsification. And in rhexis, I think Dr. Venkatesh has covered the whole rhexis part of it. But usually, say in an intumescent cataract, it's always better to use a microrhexis forceps to make sure you complete your rhexis and you do not have an Argentinian sign. Use generous amount of viscoelastics. During hydrodissection, again, if you put a lot of pressure in the eye or you try to overfill the anterior chamber, say there is already a lot of viscoelastic and you try to inject more of hydro, that there is going to be a lot of pressure and the PC is going to open up. The sign is your iris starts to pop up or there's a pupil snap sign again. So make sure you remove the viscoelastic and then inject fluid in the eye. And again, this is for cortex aspiration. So always when you're doing IA, we always feel, okay, now the nucleus part is over, so nothing can go wrong. But when you're using your aspiration port, if your aspiration port is facing towards your posterior capsule, there are more chances that you might catch your posterior capsule and that itself can cause a rent. So make sure the aspiration port is facing superiorly so that it's easier to clear off the cortex and you don't put any pressure on your posterior capsule. And it's always better you inject the IOL under irrigation, or for a beginner, it's always better to put a viscoelastic. Now PCR has occurred. What do we do next? So you always check if there is a vitreous loss or there is no vitreous loss. So how do you say that? There is irregularity in the anterior chamber depth. The nucleus, which was freely mobile, suddenly becomes difficult. The pupil is irregular, or you can see rolled up margins on the posterior capsule itself. So how do you identify this? So what do we usually say is you can always inject triamcinolone to see if there is vitreous in the AC or if there is no vitreous. So during these cases, make sure you stop your phacoemulsification, you inject visco, and then you remove your phaco probe. That the natural tendency is the minute you get to know that there is a PCR, you remove your phaco probe. That's the worst thing that I can do to the eye. I want to make sure that, my eye is nicely formed. You put the viscoelastic and then you make sure you remove your phaco probe so that the PCR doesn't extend further. So you always put, for a beginner or even for a senior surgeon, it's always better to put triamcinolone to see if there is vitreous in the AC and then proceed. And if there's a large chunk, that it's going to be difficult, please do not fetch it. You always, if you feel it's tilting, you hand it over to a VR surgeon or you convert to SICS and you remove the chunk. So if there is no vitreous loss, as I said, you remove your phaco probe after putting visco in the eye, and then you can do a vitrectomy accordingly. So how do you this is a case of, so this was an open PC already. This is a PPC case. So you do not put a lot of pressure in the eye. You make sure if you see, we are putting visco just before removing the phaco handpiece. You put visco, you make sure that open PC does not extend. This is more like a PCC. So PCC is good for the patient because you don't have to yag it later. So you make sure it stays that way and then you put IOL in the bag. So now there is PCR. How do you go ahead with vitrectomy? These are the pearls for your anterior vitrectomy. So it's always better to use a AC maintainer. So these are the settings what we usually use. And always do not pull out when you're in vacuum. That's one of the most important steps where you're on vacuum, but you're pulling the vitreous, which is causing a lot of traction. So make sure you do not pull your vitreous in vacuum. These are the settings of vitrectomy that we use. And these are the different modes of vitrectomy, that is IA cut, the cut IA mode, and the vitrectomy mode. And as I said, if it is a small piece, central opening, make sure you convert it. If it's a linear tag also, you can convert it to a PCCC to make sure that you can still place lens in the bag and it is going to be stable. So this is only if the PCR is away from the equator. So, and doing a controlled PCC will only strengthen the PC and it is not going to give way to a further thing. So which IOL to choose? This is again a very tricky thing that, it's left to each surgeon. But again, if it is a small PCR with a PCC, a single piece IOL in the bag stays very well. So if multi-piece IOL in the sulcus works well, if it is an intact bag, small PCR, and there is no vitreous loss. If it is a larger PCR with an intact CCC, you can put a 3-piece in the sulcus with an optic capture. And if you feel the support is not good enough, always go ahead with an SF IOL or an iris fixated IOL. And if it's a dropped nucleus, IOL in the sulcus and refer to a VR surgeon. So how do you again calculate the lens? Now this is again difficult because the optic of the lens is shifting towards the cornea when you're going to place it in the sulcus. So this is how we calculate the power usually, which is at the capsular bag, and how much do you subtract it from the bag to get the ideal IOL. So post-op care again is very important. It's always good to explain to the patient, say we are putting lens in the sulcus. It's always good to tell the patient that there was a complication during surgery. The lens is not placed in the bag, the lens is placed in the sulcus. It's important for the patient to know. If a patient goes to another hospital and then you have not told the patient always comes back and always questions you that, why was I not informed? So it's always important to counsel these patients, take a little more extra chair time to tell them that this is what had happened. Control inflammation with steroids and topical and systemic, frequent follow-up. If you're calling your patient, say 1 month after surgery, it's always important, if there's a PCR, call them a little more frequently so that, you can have a closer lookout at the complications. So again, what are the post-op complications which commonly happen with the PCR are again, striatic keratopathy, corneal edema, because you're going to use a lot of more power. That there is stress during when there's a PCR that happens in the eye. So the way we react and handle the tissue is also going to be different. So there can be a subtle post-operative complications with PCR itself. So to summarize, it is very important to assess the patient, like your PPC and all. We know that it is going to open up, so you take steps accordingly. In case of pre-existing PCR, you can always do an anterior segment OCT. So anterior segment OCT is very good in cases of posterior polar cataract or an intermittent cataract where you do not know the status of your PC. So when you do an AS-OCT, you know if your PC is intact or if it's opened up. So you can prepare accordingly. Proper wound construction, staining, all these play a very important role. Early indication, like I mentioned, like the deepening of the AC, the pupil snap sign, these all are takeaway that the eye gives when there's a PCR. And again, to prevent collapse of the anterior chamber, make sure we inject the OVD first and then remove the probe. Triamcinolone for everybody who has a PCR so that you know there is vitreous or there's no vitreous in the eye. Bimanual anterior vitrectomy is very important. It's always better to do it that way. Cortical removal at very low flow. Make sure the flow is low and then we do it away from the PCR, wherever the opening is. And the choice of the IOL again depends on the size of the PCR and the vitreous loss. So again, post-op care in the form of counseling and all is very, very important to the patient. So we at NN are hosting our annual Cataract and Refractive Conference. It is called the His Master's Voice, which is from July 18th to 20th. I would like to invite all of you. You can take a picture of the QR code or scan it, and just looking forward to seeing you all in Bangalore. Thank you, everyone.
Thank you. There is one slide which will be showing by Dr. Aishwarya, and one question for Tejal Madam, especially whenever there is a PCR has been taken place, please inform the patient on the table itself. That's the one point. Secondly, inform the attender also who is staying outside. Tell the thing has happened, these are the things, and this is the alternate lens we will be implanting essentially. That's an important thing. That the patient will be also happy, at the same time the attender also will be happy. Thank you, madam.
Can we have the last slide,
Ma'am, I
please?
just wish to ask one question, Dr. Tejal, ma'am. Yeah. Ma'am, you mentioned that if there is a PCR and if we are doing vitrectomy, then the cutter should be below the PCR and the aspiration port should be towards the PC, away from the optic nerve. But if I'll do like this, then PC will enlarge.
No, that was not for the PCR. That was to prevent a PCR. Make sure the aspiration port is facing towards the cortex, like under the capsular
when you're doing
rexis.
IA.
This
During
is
PCR
During
also.
IA.
Slide number 19.
Yeah, in your slides,
19.
during PCR also you mentioned that. Cutter port.
cutter has to be facing the
No,
other way.
19.
Other way, no?
Yes, not during the PCR.
Yes,
This is to prevent a PCR.
Okay.
It should be facing, superiorly.
Yes, yes.
But during your removal of the vitreous, it should be facing the other way.
Okay, thank you.
So all of you will be smiling after seeing this technique. You can just watch it.
So this is our last slide. This technique, smile technique, is by Dr. Naren, sir. So what he does over here is he's done the surgery. What you can see over here is he's maintained the anterior chamber, and now from superior to inferior, he's making one swipe. This is for a soft cataract. The swipe is from left to right, just how a smile would be. And this sweep basically creates space for the lens to be taken in. Please mind that the first important step is that you need to have a stable anterior chamber, and then the second sweep is happening, where the second sweep is debulking the nucleus and the aspiration happens. So this is also one of the techniques which you can use while you're doing a soft cataract. Thank you so much.
We have 10 minutes to take questions, if any.
Otherwise, we'll take photos.
Thank you, one and all.
Thank you, one and all.
Thank you, everyone.